Namaste Bitya, Hamesha Khush Raho Bitya. Myself Dr. Arti. Today we are going to start with a new topic which is the degenerative and inflammatory joint disease. In this series, we will start with the osteoarthritis occurs in two clinical forms. Primary OA occurs in elderly, more commonly in the women than in the men. The process begins by the end of the fourth decade and then progressively and steadily increases during producing clinical symptoms. Probably wear and tear with a repeated minor trauma, hereditary obesity, aging per se all contribute to focal degenerative changes in the articular cartilage of the joint. Genetic factors favoring susceptibility to develop OA has been observed. In secondary OA, may appear at any age in the result of any previous wear and tear phenomena involving the joint such as previous injury, fracture, inflammation, loose bodies and congenital dislocation of the hip. Morphological features include, as mentioned above, the weight-bearing joints such as the hip, knee, vertebrae are most commonly involved by interphalangeal joints of finger may also be affected. First is the articular cartilage. The regressive changes are most marked in the weight-bearing regions of articular cartilage. Initially, there is loss of cartilaginous matrix, proteoglycans, further progression of the process causing loosening, flanking, fissuring of the articular cartilage resulting in breaking off of pieces of cartilage exposing the subchondral bone. Next is a bone in which the denuded subchondral bone appears like polished ivory. This is death of superficial osteocytes and increased osteoclastic activity causing rarefaction, microcyst formation and occasionally microfractures of the subjacent bone. The margins of the joints respond to cartilage damage caused by osteophyte or spur formation. Loosened and fragmented osteophytes may form free joint mice or loose bodies. In synovium, initially there are no pathological changes in the synovium, but in advanced cases there is low-grade chronic synovitis and villus hypertrophy. The manifestation of OA are most conspicuous in large joints such as the hip, knee, back. In symptomatic cases, the clinical manifestation are joint stiffness, diminished mobility, discomfort, and pain. Next is the rheumatoid arthritis. In rheumatoid arthritis, it is a chronic multisystem disease of unknown cause. Though the most prominent manifestation of RA is inflammatory arthritis of the peripheral joint, usually with a symmetrical distribution. Its systemic manifestation include the hematogenic, pulmonary, neurological, and cardiovascular abnormalities. RA is common disease, having peak incidence of third to fourth decade of life with 3 to 5 high preponderance in female. The onset of disease is insidious, beginning with prodrome of fatigue, weakness, joint stiffness, vaguearthalgia, and myalgia. This is followed by pain and swelling of joint, usually in symmetrical fashion, especially involving joint of hand, wrist, and feet. Etiopathogenesis include the present concept on etiology and pathogenesis purpose of RA occurs in immune genetically predisposed individual to affect the microbial agent acting as trigger antigen. The role of superantigen which are produced by several microorganisms with capacity to bind to HLR-DR molecule which is called major histocompatibility complex second region, MHC second region, has also emerged. The proposed event in immune pathogenesis of RA is under in response to antigen exposure in a genetically predisposed individual, HLR-DR, CD4 plus T cells are activated. These cells elaborate cytokines and important ones being tumor necrosis factor, interferon, interleukins 1 and 6. These cytokines activate the endothelial cell, beta lymphocyte and macrophages. The activation of B cell releases IgM antibody against IgG. This molecule is termed rheumatoid factor. IgG and IgM immune complex trigger inflammatory damage to the synovium, blood vessels and collagen. Activated endothelium cell express adhesion molecule which stimulate collection of inflammatory cells. Activation of macrophages release more cytokine which causes damage to the joint tissue and vascularization of cartilage termed pannus formation. Eventually damage and destruction of the bone and cartilage are followed by fibrosis and ankylosis producing joint deformity. Laboratory findings include About 80% of cases are seropositive for RA factor, actually DR4 and DR1 associated in familial cases, anti-CCP for evaluation of association of RA and HLA, and other laboratory findings include the mild normocytic normochromic anemia, elevated ESR, mild leukocytosis, and hypergamma globulinemia. Now the macroscopic features, our main finding are seen in joint, tendon, and less in extra-articular tissue. In articular lesion, RA involve the small joints of the hand and feet and symmetrically affect the joint of wrist, elbow, ankle, and knee. Microscopic examination include the numerous folds of large villi of synovium, marked thickening of synovial membrane due to edema, congestion, and multi-layering of synovites. Intense inflammatory cell infiltrate in the synovium membrane with predominance of lymphocytes, plasmacells, some macrophages at place forming the lymphoid follicle. Foci of fibrinoid necrosis and fibrin deposition. The penis progressively destroy the underlying cartilage and prochondral bone. Extra-articular lesions include non-specific inflammatory changes are seen in the blood vessels, lungs, pleura, pericardium, myocardium, lymph node, peripheral nerves, and eyes. But one of the characteristics extra-articular manifestation of RA is occurrence of rheumatoid nodule in the skin. First is the juvenile RA found in adolescent patient under 16 years of age, characterized by acute onset of fever and predominant involvement of knee and ankle. Fletty syndrome consists of polyarticular RA associated with splenomegaly, hypersplenism, consequent hematologic derangement, and last one is the ankylosing spondylitis and rheumatoid spondylitis. It is rheumatoid involvement of the spine, particularly the sacroiliac joints in young male patients. The condition has a strong HLA-B27 association and may have associated inflammatory disease such as the inflammatory bowel disease, anterior uveitis, and Reiter syndrome. They all are the autoimmune disorder. They are related to each other. This is my reference books. I hope you enjoy this session. If you have any query, please mention it in comment box. I will try to resolve it. Thank you so much. Bye-bye. Take care.